So, Sue, thank you so much for being on the show.
Jessa, my absolute pleasure.
We've had so many interactions, and it's nice to finally talk to you on the podcast. I'd be curious if you don't mind sharing your story of how you came to this work. Why is it you do what you do?
Well, it's kind of a convoluted story.
Okay.
Um, my husband has always talked about his work at home. So many, many years ago, when I was still a stay-at-home mom and then doing volunteer work and then doing other kinds of work, he would talk about his research, bounce ideas back and forth. My family always joked that when Viagra came out, I knew more about erectile dysfunction than the average urologist in private practice, which was probably true then in
Probably true.
1998,
Yes.
and probably still true. When we moved from Boston to San Diego, my husband retired from the university. We opened a private practice, and okay, I went to work to help him out. Didn't really know what I was going to be doing, but I helped answer the phone. I basically worked with the practice admin to open up the practice, but we had, staff around.
Hmm.
Very quickly came to learn that our nurse practitioner, we didn't really have enough work for her. And she went back to the practice she came from, but we had started a clinical research project. And my husband looked at me and goes, "You're going to do clinical research." I had done bench research many years before. My dad was a researcher. I had worked in other people's labs. So I had that background, but no clinical research. But as we did things in the practice, I continued to listen to him and learn. I went to
Hmm.
the professional conferences, the International Society for the Study of Women's Sexual Health, Sexual Medicine Society of North America, International Society for Sexual Medicine, and I listened and I learned. And over time, I recognized that while I had been supporting my husband in his passion, it had become my passion,
Yeah. Yeah.
in particularly women's sexual health, because so very little was known.
Hmm.
I myself was a woman experiencing first hypoactive sexual desire disorder in my early 50s. And as I went through menopause, obviously experiencing what happens when your hormones change. I was lucky enough to be married to one of the world's leaders, so I've always had treatment. So I went through menopause very easily. People think that once they have the vasomotor symptoms gone, they're past menopause and they're in post-menopause. Well, menopause and post-menopause are the same thing. You're in menopause until you die.
Yeah.
And over the years, as I said, I've done a lot of clinical research where I've written my own protocols and worked with sponsored companies. I also have worked with a lot of patients, and because our sex therapist is qualified to be a supervisor of sexuality educators, she had suggested to me that I get my certification in sexuality education. So I am a certified clinical research coordinator, and I'm an ASEC certified sexuality educator, which allows me the opportunity not to treat patients in our practice, but to talk to them about things.
Yeah.
I work with them. I'm a surgery scheduler, and I work with them about surgery. I work with a lot of menopausal women, many of whom are very hesitant to take hormones. And so, talking to the doctor's wife, if he's putting me on these hormones, then clearly they're not something that's going to cause heart attack, stroke, early dementia, just the opposite. And so that gives them confidence. So when they've talked to the doctor, but they've also taught, and they talk to the nurse practitioner, but they also have an opportunity to talk to me. And so it's a lot of fun to have the interactions with patients, both from the clinical research side and from the patient care side.
Yeah. So you must hear so much from all these women about what they're struggling with in menopause, right? Like
Well, it's
what are some of the stories you're hearing and the things that bring them in? Sometimes traveling across the country, right, to come see you
yes,
in San Diego.
yes. I think what's sad is that women will say, "I want to go through menopause naturally." And I said, well, when man evolved hundreds of years ago, women didn't live long enough to go through menopause. Would they go through, if they develop type 2 diabetes, would they treat that naturally? If they develop cancer, would they treat that naturally? If diabetes, I think it's the diabetes, hypertension, hypercholesterolemia, would they treat any of those naturally? They would not think twice about being treated. And while I would never say to a woman, "You must be treated," people have to open up their eyes and realize that we live so much longer, and we're living half of our lives with our ovaries not working. The first, 10, 12 years of our lives, and then the last 40 years of our lives. And it's really what you want in terms of quality of life. We believe in monitored care. That means that we carefully monitor the symptoms women are experiencing and the treatments we're giving them. But I can't tell you how many women said, "Well, my sister has breast cancer, so I'm afraid to even put anything into my vagina." Well, the treatments you put in the vagina aren't going to go into the bloodstream. If you're putting an estradiol, it goes into the bloodstream a little bit for the first 2 weeks, and then the vagina wall is thickened enough it doesn't go through. If you use intravaginal DHEA, which is actually the preferred, they've done tests, nothing goes into the bloodstream. So to have that reassurance is really important. But women are losing their relationships because they can't have sex. We talk about gray divorce, and I really believe, if I can use the vernacular, well, I guess I'll clean it up a little bit. But it's a man with a not fully erect penis that he can't get into an unlubricated vagina.
Yeah, this is not working very well.
Bimbo blonde on his arm, he needs a lubricated vagina. If his erection is firmer, it'll slide into her vagina much more easily. And if hers is lubricated, and I'm not just talking about using lubrication you can get at the store.
Right.
People are even afraid to use that. They feel like, if I use a lubricant, that means there's something wrong with me. Hell, my husband and I have used a lubricant since we're in our 30s. It just makes sex more fun. And you can change the lubricant just like you can change up your sex toys. But having the hormonal milieu corrected allows your body to naturally lubricate, which makes sex more fun. I mean, I'm married over 50 years. I'm still having sex with my husband, not as often as I did when I was in my 20s.
Yeah.
But the sex I'm having is just as good as when I was in my 20s because I've been treated. If I didn't, we wouldn't be having sex, and I don't know if I'd still be married. My husband is a sex doctor. He has to practice what he preaches.
Right. You got to walk the walk. Yeah.
Yeah. And it's so sad. And for women they believe that menopause is only the vasomotor symptoms because that happens, within those first few years of your last menstrual period. They don't understand that the dryness, which eventually turns to, vaginal atrophy, happens over the next 5, 6, 7, 8 years. And so they don't associate it with menopause. So sitting down with a woman and say, this is my experience, this is what's happened to me, is so reassuring to these people. They want to have sex, they want to have an active sex life, but more importantly, they want to be healthy. It's more than just sexual life. It's your cognition, it's your muscle mass, it's your bone density. And while I can't give you exact numbers, we know that being on FDA approved bioidentical hormones is really helpful unless you have a specific contraindication. And so that's why we do not believe in the same medicine for all people, but we do have a general paradigm for most menopausal women that works.
Okay. So let's see. You're sort of talking about two of the main myths, I think, that first of all, menopause is natural. So why should we treat it? And I guess, when you compare it to diabetes or cancer, I'm thinking, well, those don't happen to everybody, and menopause happens to every female.
Right.
But you're also saying we were never meant to live 40 years with our ovaries not working.
If we think about it, your lifespan, you lived until you were fertile at 12, 13. You got married at 15 and had your children, and you died by the time you were 35. So you lived long enough to see the next generation get married and have their first baby. I mean, that was what man didn't live past 40 or 45 until the 1800s. Seriously. And we really didn't live as old as we are now into the last 100 years because of all the medications we have. Allows us to live, whether you're on Lipitor or metformin or whatever it is that you need. People just did not live long enough to spend 20, 30 years in menopause.
Yeah. And then the other big myth, I think, is, or at least what I'm hearing from you as a myth, is that somehow these hormones are dangerous to be taking. The supplementation has got risks and so many contraindications. And if it isn't cancer, it's going to be dementia or whatever. Where does all that myth, where's that all come from? And
it comes from the Women's Health Initiative. Before that, I think about 65% of menopausal women were on hormone replacement. And the Women's Health Initiative, first of all, it didn't use bioidentical hormones. It used horse urine, and the reason we talk about bioidentical is if the chemical of the medication you're taking is the same as the chemical your body naturally produces, we can measure how much. So we can monitor how much estradiol, how much testosterone, how much progesterone. If it's not bioidentical, there's no way to measure it. And the very first estradiol was Premarin, pregnant mare urine. There was no way to measure. So gynecologists said, just, here, your symptoms are gone, you're good. And that's why even today, many gynecologists do not believe in monitored care, because when they trained, that's what it was. It was not possible to monitor it. The Women's Health Initiative came out and using non-bioidentical showed there was a slight increase in cancer in one of the two arms. There was no increase in the other arm. But some of those calculations weren't even done perfectly initially. They went back and recalculated. The news took it and ran with it. When the recalculations were done, when it was revealed that only one arm had increased risk, they never went back and changed any of that. But it was such a scare that today, instead of 65% of menopausal women being on hormones, it's about 5%, somewhere 5 to 7% of women. I don't remember exactly, but it's somewhere in that range. There was a study done 10 years after the WHI that revealed approximately 45,000 women, postmenopausal women, had died of other causes that would have been prevented should they have been on hormone replacement.
Wow. What kinds of things would kill
heart
women?
disease? Heart disease. I mean, the risk of heart disease is far greater than the risk of cancer. And while there is a small segment of people that should not be on hormonal, systemic hormones, that is not the general population.
Wow.
So, I mean, I am on systemic testosterone, systemic estradiol, systemic progesterone because I have a uterus, and then I'm on local medications. I put local DHA into my vagina, and the only compounded we will sometimes compound DHEA because the FDA version is very expensive, but it doesn't matter exactly how much DHA goes in, so it doesn't matter if it's not exactly the same, and that's why you worry about compounded products. You don't know what's in them. And then we do use a compounded testosterone and estradiol cream on the vestibule. And while you're not supposed to compound testosterone and cream because it layers, the amount of testosterone is so minuscule that it doesn't matter if it layers. But ladies, if your doctor is saying, I'm going to give you a pellet of testosterone, there is this one FDA-approved pellet, Testapel. The rest of them, we don't really know what's in them. If your doctor says, I'm going to have compounded testosterone, so you could just do one click out of a click container, which is how we do the compounded testosterone estradiol. The testosterone layers in the cream. That's why the FDA very specifically says, do not use testosterone in anything other than a gel or a solution, which is the way the topical testosterones are. Obviously, there are other testosterones for men, but since women need about 1/10 of a dose, we can't use the men's pills. You can use injection, but the injection is so small, it's difficult to do that. So that's why we really recommend the gel that's the easiest. But obviously, your doctor has to be comfortable with prescribing that, and you have to be comfortable with using it.
Yeah.
I think another myth is a gynecologist will tell you, they'll either tell you estradiol will turn into testosterone, which is wrong. The cascade goes the other way, starts with cholesterol, and it goes down to 21 carbons on testosterone and 19 for estradiol. It can't go backwards.
Okay.
So if your aromatase is working in your body, testosterone will naturally turn into estradiol. But as you age, it's not going to be enough. You need to add the estradiol.
Yeah.
But when the gynecologists and I don't mean all gynecologists, I have many friends who are very knowledgeable, but when physicians in general, or people in general say, well, we have far more estradiol in a woman's body than testosterone. Because if you look at the graphs, it's much higher for the estradiol. It's because it's in a different unit.
Yeah. Yeah.
If you put them in the same unit, we have 5 times the testosterone in our body than we have estradiol.
Yeah.
And most clinicians don't know that. So how would women know that? And so that's why in our practice, again, monitor to make sure that we're not giving excessive testosterone. That's part of what we do. When people say, I'm going to turn into a man, I tell people I've been on testosterone for almost 23 years. I was a first soprano when I started. I'm still a first soprano. And the only way that you're going to get masculinization from testosterone is if you give a man's dose, like a transgender woman becoming a man would be given a man's dose. We're not doing that. We're giving 1/10, which is approximately how much testosterone women have, is 1/10 of what men have.
Yeah. Another thing I'm thinking, since my own doctor did this, just prescribe Premarin, which is only one of these 3 essential hormones too, right? A lot of this treatment has not been including at least testosterone, right? Historically.
So is Premarin bioidentical, or is it still pregnant mare urine?
I assume it's still pregnant mare urine, right? So
So we would
after
not
talking
prescribe.
to Dr. G, I stopped. I put it away. But it also seems like this hormone treatment, they didn't always cover the whole range of
Well,
hormones you need.
they were fearful of testosterone, but if you go back in time to the 1930s, we had organotherapy, where they literally took the organs from animals, ground them up, and that's how they initially replaced testosterone. And they did it for men and women because they took the ovaries in women and ground them up and replaced women that way, not knowledgeable enough to realize that the ovaries made testosterone and estradiol.
Ah,
And then when they were replacing what they thought was estradiol, it was estradiol and testosterone. And it's really only when Premarin came out, I believe in the 60s, that we no longer talked about testosterone in women. So it's really interesting. And Jessa, you would be surprised to know that the first treatment for breast cancer was testosterone.
really?
Mm-hmm.
Huh.
Crazy, right? We
Yeah.
don't use that anymore as a treatment. It's not an effective treatment, but we look at trans women. So they're men becoming women. No, I'm sorry, the other way. Trans men, we're giving them high doses of so they started as women, and we're giving them high doses of testosterone. So because they're becoming men, transitioning to men, they do not have a higher rate of breast cancer.
Yeah.
It doesn't, it doesn't
Yeah.
cause that. So many of the fears are the hype from the newspaper. And of course, that was the estradiol. That wasn't testosterone, because they didn't even think to look at testosterone in women at that point. But
Right.
many of our fears are lack of knowledge,
Yeah.
which is true in every field, not just in medicine, in everything in life.
Right.
Fear comes from lack of knowledge.
Right. Now, is your clinic, are you guys doing the data and the research to counteract this women's health initiative thing? Like, because you've been in the clinic, you've been treating people for decades with monitored hormonal replacement, right? You must have a lot of data about the safety and
Well,
efficacy and everything else.
we basically started treating women after Viagra came out, and women started calling and say, "What are you going to do for me?"
Yeah.
So that was 1998 when Irwin was in Boston. Our clinic was open in 2007, and we do have a lot of data. I think there are a lot of data published. There was in the Scandinavian countries, they tend to have databases that include everything. And so those researchers can mine those databases and get so much information. There was a publication from Finland and more recently from Denmark showing the use of estradiol. I believe one of them showed it was cardioprotective, and one of them showed that it had no cardiac or stroke increased events. I don't want to misquote. So please, if you're watching this, listening to this, go do your own research.
Yeah.
But there are, these are in huge numbers of data points that we can't just assemble in our office, but we do a lot of chart reviews to look at things. And we do chart reviews on things that we are kind of unique to us. We tell patients we treat the zebras in sexual medicine, the odd things that either your doctor says, you can't, I don't see anything, there can't be anything wrong, or I never heard of that doesn't exist, or I don't have time to deal with this, find somebody else.
Yeah.
If you can be treated easily, you can go to your local doctor. So we see a lot of weird stuff. And sometimes I just tell the patient that when they call, well, I have something really weird. I said, well, then you're the kind of patient we love to see. We thrive on the weird patients. And GSM, genital urinary syndrome menopause, is not a weird patient. But we see a lot of those people because their local doctors don't know what to do or afraid to do, don't want to deal. And so that's why these patients come to us,
Right.
not just local patients. People will fly to us, but then they have some unusual things. For instance, neuroproliferative vestibulodynia. The vestibule is basically between your labia minora and your vagina, and it sort of folds in, so you don't really see it that much, but it can cause a great deal of pain for people who have mast cell aberrant disease, because the mast cells collect there. They send off nerve growth factor, and then the nerves collect there, and it becomes very painful. And when you cut yourself, that same process happens, but once it's healed, everything goes away and you don't have pain. Unfortunately, in the vestibule, there's no keratinized layer on there, so it's not protected by dermis. It's exposed to everything, and it can react to things touching it. But we have a large cohort of patients that the only treatment at this time, we hope someday there'll be medical treatment, and I'm part of a summit that's looking into that. But at this point, the only real treatment is to remove it surgically. And it's literally the top layer of the vestibule that it's taken off. But we've done a lot of research with that because we have such a high number of people doing that. And we've looked at
Right.
looked at the mast cells. And these people go to their doctors and they say, I don't see anything. It's in your head. Go away for the weekend.
Right.
But I
Right.
want to bring back to menopause. This was only identified in 2004.
Hmm.
So there are women from beforehand that nobody knew what neuroproliferative vestibulodynia was. And now they're coming to us. And first, we need to treat their menopause symptoms because otherwise their skin is very fragile.
Right.
Menopausal skin untreated can tear easily. It's friable is the word. So you can't sew it together after surgery. So we need to get them well, I was going to say well hydrated, but we need to get
Supple
them,
and,
yeah,
yeah,
we need to
right.
get them, we need to get them hormonally replete instead of hormonally deplete so that the skin is healthy. And then we can remove the vestibule. And I don't know how many women out there are like that and just retired from sexual function, from any sex because it's way too painful. There are women who could never put in a tampon. It was painful their whole life, and they may have endured sex a few times to have their children. But because nobody knew anymore, I mean, nobody knew anything about this until the last 2 decades.
Right.
And so for us to start to see these menopausal women and care for them is such a blessing because they're women who it may be they just want to wear tight pants, and it may be they want to be intimate with their partner again. And I think those are the stories that get to me the most.
Yeah.
That they struggled with this for years and years and years, and nobody knew any better. And now they're older women. They say, oh, it's just menopause. And they go, okay, I can live with menopause, but it's not just menopause. It's this neuroproliferative vestibulodynia. And that's something that we've presented at conferences so that people are aware of this, because we don't think of that in the older generations because we just assume, and that's our problem. We just assume.
Right. Right. All right. So paint just a little picture for me of the kinds of symptoms people have before and the kinds of experiences menopausal women might have, and then what's different after hormone replacement.
So obviously everybody knows vasomotor symptoms, night sweats, hot flashes, and those are the early symptoms.
Right.
Then you start to get dryness in your vagina, and it can get raw. It could tear if you're trying to have sex. It could be extremely painful. Your clitoris could get very small. The entrance to your vagina can get smaller, and your urethral meatus, which is where your pee, can become telescoping, literally stick out, making you much more susceptible to UTIs. Urinary tract infections are very common in older women who are not estrogenized or androgenized. All of these tissues have both androgen and estrogen receptors. And while many people say estrogen, yes, the estrogen is important, but so are the androgens because they have both sets of receptors and all of these tissues. The urethra border, I mean, it will border on the vestibule. It's different tissue, but it literally telescopes, it sticks out. But when you go on the hormones, the urethra goes back to its normal shape. The clitoris can grow to its normal size. It won't become clitoromegaly. It doesn't grow to be huge. It goes back to a more normal size. The labia minora, which have resorbed, can grow again. They may never grow all the way down to the posterior fourchette, but they will grow again. The lubrication returns and the rugae, which is the accordion inside the vagina, which is what allows it to stretch and allows you to have sex or have a baby without, that allows it to move. The rugae return. The red rawness will disappear. The pallor, which is the white color. I mean, it sounds really weird to have redness and pallor, but it's erythema and pallor. All of that will go away with treatment. And my husband he will often show pictures of his patients over time, and you can see visually the changes because every time our patients come in, we take pictures of the vestibule, and not with an iPhone. We do it with a scope that's recorded in the patient chart, and so we're able to show them this is what you looked like when you came in, and now 12 months later, this is what you look like. And in our practice, we often encourage people's partners to come with them if they can. And if you're comfortable, it's your body, it's your choice. But if you'd like to have your partner, we welcome them because then he or she can see that it's not that you don't want to have sex because you don't love them. It's because it is so painful.
Yeah.
And look at the red rawness in a menopausal woman who's 10 years past her last period and she hasn't had any treatment. It's, it just looking at it is uncomfortable.
Yeah. So, okay. So the pain is going to resolve. It's going to be way more comfortable. Those tissues plump back up. I assume it does something for libido as well.
So testosterone is very important for libido. And so very often you will have what's HSDD is hypoactive sexual desire disorder. That's low libido that distresses you. If it doesn't distress you, it's not a diagnosis. If it distresses you, it will. And I always say when we've done the work in this that, and we've done research on this language and around the world, women do not relate to stress. Distress is when their kid falls off the jungle gym or their husband falls and breaks his hip. That's distress. They're bothered by it. But I believe that because women don't understand there are treatments for low libido, if
Yeah.
they knew there were treatment, they would be more distressed, like treat me, treat me. So
Yeah.
we have two treatments for premenopausal women that are FDA approved. One is a pill you would take every evening at bedtime. It's flibanserin, trade name is Addy, and the other one is an auto injector you use before you plan to have sex that will increase your interest. And that is bremelanotide. The trade name is Vyleesi. But they were both tested in menopausal women. And while the FDA didn't approve it because the FDA required that they be tested separately, which is silly. They're both central nervous system drugs. All of our other CNS drugs were for all men and women. These, they to make more money or for whatever reason, they needed to do it separately, but we use them in postmenopausal women and in men because they're CNS drugs. For menopause, for perimenopausal and menopausal women, testosterone also can treat low desire. And don't forget that sex therapy can also treat low desire. So we believe that your brain is neuroplastic and it changes over time. And that's why you develop HSDD. And any and all of these treatments can, based on the individual person, can treat HSDD. We actually did a clinical trial of the Addy, the flibanserin. Half the people had just flibanserin and half had flibanserin and sex therapy throughout. And while I won't say all, most of them got better. The ones who were on sex therapy got better more quickly, had a more robust response. So we believe in all of that. ISSWISH has a process of care on HSDD. We're actually in the process of revising that. Should be out next year. With all the latest treatments. For me personally, I developed HSDD early on before I really had my menopausal symptoms. And so I went on testosterone. And I put it very simply. If my desire and my sexual activity was 10 out of 10 when I was in my 20s, it had dropped down to, basically zero, avoiding sex without even realizing it. But my husband recognized it. And what actually happened is a funny story. The female sexual function index was developed in success if you treat somebody or not in women. We had something equivalent in men. It's an international index of erectile function, which was developed to show if Viagra worked. So he brought the FSFI back to the house and said, oh, take this. And I filled it out and he goes, holy, you've got FSD. And I knew we weren't having a lot of sex. And I was thinking, oh, it's because my husband's not getting good erections, which wasn't true, by the way. But I just mentally, I didn't realize it was me, which is considering how much I knew about the field. I didn't until I took that.
Yeah.
So I started on testosterone. Testosterone brought me back to probably a 1 or 2 out of 10 compared to when I was young. And that was totally fine. And then literally 3 months after Addy was approved by the FDA, before it was available to prescribe, the testosterone stopped helping me.
Oh.
I went back to having HSDD, tried Wellbutrin, which is another drug we occasionally use, didn't help. And as soon as Addy was available, it was prescribed for me and I've been on it ever since. But I share that not because I'm trying to promote a medication, but because my sex life, my interest and my sexual activity, because all these drugs not only help with desire, but also arousal and orgasm. They're all very related. My sex now, as I said at the beginning, when we started, I can't have sex as often as when I was younger. My body is older, but my sex is 10 out of 10.
Yeah.
Maybe not all the time, but most of the time.
Yeah.
So for me, it was having the testosterone and the estradiol to restore my body. And that worked fine for a long time. And then it was no longer enough. And I added the Addy. And so I've been on Addy for, I don't know, maybe 8 years or something.
Yeah.
And that has changed my life. And it's not, people will say, oh, it's going to make me a nymphomaniac. And I said, well, it reboots your brain. It returns you to where you were when you were young.
Yeah.
If you were a nymphomaniac when you were 20, then it'll make you a nymphomaniac. But, most people weren't, and they're not going to become it. And on the days that you feel lousy and you don't feel like having sex, it's not like, okay, I'm going to have sex. If you feel lousy, it really brings normalcy back.
Yeah.
but it not only to your body and the sexual response, but there was a playfulness in our relationship that I hadn't realized was missing
Mm,
until that came back. So it's very interesting. Our bodies and our brains are so attached that I think we sometimes forget that if we're not healthy in our bodies, our brains aren't going to respond properly.
yeah. And maybe that's your takeaway, but I guess I'd love you to close with what's the one thing you want women to really take away from this conversation?
The one thing I want women to know is that you know your body. And if you're going to a clinician who says there's nothing wrong and you think there is, find another clinician. My husband taught me many years ago when he first started practicing medicine, if you listen to a patient long enough, they will tell you what was wrong. You know your
Mm,
body better than anyone else. We believe in patient-centered medicine. You and your clinician choose together what you believe will work best for you. Don't ever let a doctor tell you there's nothing wrong if you believe there is. Don't ever let a doctor tell you you have to take this if you don't want to. It's a shared community medicine, and you know yourself. Find a doctor you trust. People spend more time looking for a used car than for a doctor. Find somebody that you trust and work together with them, because that's how you're going to get better.
yeah. All right. And on that note, how do people reach you, the clinic, in case
So
they,
our clinic is San Diego Sexual Medicine. You can find us on the website. You can go san diego sexualmedicine.com, or you can do SDSM. Our initial is sdsm.info. You can call us at 619-265-8865. I just want to share with you, because we have so many complicated cases, we're set up to have approximately a 3-hour new patient visit. And so therefore we are a cash-based practice, and we don't want anyone coming in with surprises. So everybody who's interested can do a 10-minute, what we call a courtesy call, directly with Dr. Goldstein. He'll listen to your symptoms. Maybe he'll say, you know what, there's somebody near you that can help you. Or he'll say, these are the tests we would do. And then the office staff can give you a good faith estimate. So you can make an informed decision if you want to become a patient or not. But just give us a call, 619-265-8865. Our staff is wonderful, although I have to say our front office staff are all brand new and they're still learning. So if things get too complicated, they may pass the phone to me. If you want to talk to me, you're always welcome to call the office and speak to me. I am not a provider. I'm not going to diagnose you. I'm not going to treat you, but I'm happy to talk to you about your issues, because I believe that everybody has a right to health, and that includes sexual health, and that comes from the World Health Organization.
Yeah. Well, thank you so much.
Jessa, it was a pleasure.